Okay, so my topic was types of arthritis. So we'll go ahead and start. All right. All right. So our learning objectives is to define arthritis, learn about different types of arthritis, their etiology, risk factors, progression, signs and symptoms, and how we would treat and evaluate these patients. We will give some evidence-based practices that help treating these patients, as well as referrals, who we would refer these patients to, and need for follow-up. So first of all, what is arthritis? It is also known as inflammatory joint disease. It is a disease that is characterized by inflammatory damage and or destruction of the synovial membrane or articular cartilage of the joint. And it also may manifest with systemic signs of inflammation such as fever, elevated white blood cells, malaise, anorexia, and high levels of fibrinogen in the blood. There are two subtypes. The first one is infectious inflammatory joint disease, which is caused by an invasion of the joint by a bacteria, virus, fungus, mycoplasma, or protozoa. These agents usually invade the joint by a traumatic wound, surgical incision, contaminated needles, or they may be introduced to the joint from a site of infection by the bloodstream, such as bones, heart, valves, or blood vessels. Non-infectious inflammatory joint disease is the most common form of arthritis. It is either from immune reactions or the deposits of uric acid in the joints. The types of these examples of these types of arthritis will be covered in this presentation. All right, so prevalence. In 2012, it was estimated that 52 million Americans, 52.5 million Americans were affected by arthritis, which comes to be an issue when the disease actually causes a physical limitation on their daily activity. In 2012, the CDC projected that nearly half of these Americans have activity limitation and encourage health providers to use evidence-based practices to improve this phenomenon. The CDC further projects that the incidence of these limitations will exceed 25 million by 2030. There are many types of arthritis, and for the purposes of this presentation, osteoarthritis, rheumatoid arthritis, gout, and juvenile idiopathic arthritis will be covered. All right, so we'll start with osteoarthritis. It is the most common form of arthritis. It's a primary defect. The primary defect is the loss of articular cartilage in the joints. It comes from the cartilage starts to thin, flakes off, and exposes the bone ends to rub against each other. These ends become dense and hard or sclerotic, and they form cysts. Then break due to these cysts then break due to the increased pressure. Cartilage continues to erode away, and eventually causing a joint effusion. Osteoarthritis can be found primarily in the major joints where the greatest amount of weight is bared. Risk factors, trauma such as sprains, strains, dislocations, or fractures. Long-term stress on the joints commonly found with patients who are athletes, ballet dancers who do repetitive physical tasks, and patients who are obese. Let's see, joints instability results from the damage to supporting structures, also contributes to osteoarthritis. Congenital or acquired skeletal deformities, and long-term disorders such as hemophilia, and that causes prolonged or chronic bleeding into the joints, or hyperparathyroidism, which causes the bone to lose calcium. There's another drugs such as colchicine, steroids, and indomethacin, which actually stimulates collagen digestion enzymes in the synovial membrane. All right, so progression, it's usually asymptomatic until the patient's 50 or 60 years old. As further damage occurs, signs and symptoms progress. All right, so signs and symptoms of osteoarthritis. Pain, first of all. It's usually in one or more joints with weight bearing, use of joint, or load bearing. Pain usually resolves after joint or after rest or with rest. If it's not relieved by rest, it's usually accompanied with numbness, tingling, or prickling sensations, paresthesias. You have joint stiffness, which is difficulty initiating movement in the joint or loss of range of motion. Usually it's relieved after a few minutes, and it rarely continues after 30 minutes of movement of the joint. Limited range of motion due to the pain associated with the cartilage degradation. There's also can be present as crepitus, creaking, or grating. These patients may also present with a limp when ambulating, and it may be worse after strenuous activity, and pain will be present. All right, so treatment, radio or x-rays or radiological studies are rarely needed. MRIs can be used to actually see how much degradation is done to the cartilage. Braces can be used to help support those external, like tendons and ligaments issues, and reduces pain and helps with biomechanical abnormalities. Non-pharmacological interventions would include exercise, because it improves tone of muscle, range of motion, and also will actually improve symptoms along with weight loss. Pharmacological would include anti-inflammatory meds such as ibuprofen or other NSAIDs, but be careful with these because they can cause GI bleeding or discomfort or serious health problems, okay? Surgical, this needs to be concerned with, or this can be concerned, this can be used if the patient age is appropriate and their loss of ADLs is an issue. So that's also taken into consideration when replacing a knee or a hip. All right, so we move on to rheumatoid arthritis. First off, we'll start by defining it. It's a chronic or systemic inflammatory autoimmune disease distinguished by joint swelling and tenderness, which results in the destruction of synovial joints, leading to disability and premature death. So there's no exact cause. It is autoimmune, but it appears that patients are genetically predisposed. There's no there's no antigen that can be identified, and it leads to synovial lining of the joint becoming inflamed and congested with T lymphocytes, B cells, macrophages, and plasma cells. The result of this causes proliferation of the synovial membrane, which erodes the bone, resulting in altered function, joint destruction, and deformity. So risk factors, again, genetics. Gender, it's more prevalent in women. Environmental factors such as geographic area of birth, diet, socioeconomical status, smoking, hormones. Women who have the disease and who become pregnant actually have less symptoms of rheumatoid arthritis, and they get worse after they're postpartum. So hormones have some kind of effect. They don't know why or what. All right, so progression, the incidence increases with age. Patients will be having symptoms in the joints of hands, feet, fingers, and ankles. Then this disease spreads to the surrounding ligaments and tendons, causing pain, joint deformity, and loss of function. The disease then moves to larger joints such as the knees, elbows, cervical spine, and also tissues of the heart, lungs, kidneys, and skin. It leads to disability and then to premature death. Signs and symptoms: joint inflammation, tenderness, warmth, pain, and swelling. Commonly seen in the hands and the feet. And they will often express having difficulties in performing their ADLs without the assistance of others. Evaluation and treatment. So ultrasound can be used to detect early inflammation if there's none detected by physical exam. There's no really, it's useful. Conventional radiology is useful in monitoring the progression of RA. It can show soft tissue swelling, loss of joint space, loss of bone density, subluxation, which is like a partial dislocation of the joints, and articular erosions. The presence of erosions is an indicator of a poor prognostic outcome. Extra-articular findings such as this disease affecting other tissues in the body would be pericarditis, pulmonary effusions, interstitial lung disease, entrapment of neuropathy such as carpal tunnel syndrome, and skin, rheumatoid arthritis or peripheral vasculitis may present themselves. Lab studies would include an ESR, which is SED rate, or CRP, and inflammatory markers can also be used for infection. Patients with a high CRP are associated with severe disease. Treatment of this disease would include DMARDs, which is disease-modifying anti-rheumatic drugs, such as methotrexate, sulfasalazine, and hydroxychloroquine. In addition to biologic DMARDs, which would be infliximab, etanercept, or adalimumab. The goal of these drugs is to suppress the immune response and control inflammation. These patients need to be monitored closely because these patients, if they're not having any improvement, they need to be moved on to another type of medicine. And also, these patients, their immune response will be lowered, so they can acquire infections or diseases. Steroids can be prescribed with DMARDs to assist in reducing inflammation, because a lot of times these medicines, they don't work after a few months, or they don't start working after a few months. NSAIDs, again, for pain reduction. All right, next one, gout. So it's uric acid buildup or under excretion of uric acid. This can build up in the joints, causing pain and inflammation. So risk factors would be high intake of certain foods such as red meats, fructose, and alcohol. Gender, it's more prevalent in men, and it's rare among children and premenopausal women. Patients who have kidney disease or kidney stones or renal impairment are also increased risk. Progression. All right, so either you have high uric acid in your blood in your joints and you just have it for life, but you can be asymptomatic. And then you have patients who present with acute gouty attacks that result from elevated uric acid that is exacerbated by alcohol intake, trauma, or drugs. And the other form is tophaceous gout, which is a chronic stage of the disease, which your body cannot excrete uric acid, and also results in uric crystal deposits called tophi in the cartilage, synovial membranes, and soft tissue. Hyperuricemia is associated with chronic diseases such as hypertension, heart disease, type 2 diabetes, kidney disease, and metabolic syndrome. All right, so signs and symptoms, like I said before, severe pain in an affected joint with redness, swelling, and hot joint. 50% present with greater toe pain, which is known as podagra. It also can affect other parts of the foot, elbows, wrists, or fingers, as you can see in the picture there. All right, so evaluation treatment, you need to do a thorough physical and history, all right, just to, back up your diagnosis of gout. You need to tell these patients to control their diet, to include a diet that is high in vegetables, avoid alcohol, and have a little bit of meat. Pain control, avoid weight-bearing, avoid any weight-bearing infected joint until the attack has subsided. Ice packs help reduce inflammation and pain, and the use of NSAIDs to control pain as well. Anti-hyperuricemic drugs such as allopurinol can be used, and also help with reducing gouty attacks. Okay, so now we have the last one, juvenile idiopathic arthritis. That's a childhood form of rheumatoid arthritis. Risk factors, there is no known cause. Onset can affect children from 1 to 10 years old and is more prevalent in females. Progression, there's 3 modes of onset. Oligoarthritis, which has affects 3 or less joints. Polyarthritis, which affects more than 3 joints, and Still disease, which is a severe systemic onset of juvenile arthritis. There's differences between adult and juvenile rheumatoid arthritis. Large joints are mostly affected in the juvenile. Chronic inflammation, such as the anterior chamber of the eye, also known as chronic uveitis, is affected. Serum tested tests for rheumatoid factor may be negative. Subluxation and ankylosis of the cervical spine may occur. If it continues through adolescence, patients can have severe effects on growth and adult morbidity. All right, so signs and symptoms is pain in large joints. Caregiver may also report fever, rash, or malaise. Patient may also report vision changes or from the chronic uveitis. Evaluation and treatment. Serum rheumatoid factor anti-nuclear antibody can be done. If negative, it is likely the disease will resolve prior to adolescence. Positive rheumatoid arthritis is linked to worse prognosis in lifelong arthritis. Also, if it's positive for chronic uveitis, is commonly present. CBC, ESR, and CRP may be evaluated to show leukocytosis, inflammation. NSAIDs are the primary drugs to control pain, and also DMARDs, such as methotrexate, can be used with success. All right, so we move on to evidence-based practices. So osteoarthritis, they say to promote exercise because it will decrease pain, control your weight, and increase your joint flexibility. Through exercise, you will strengthen your muscles, which will help to take the load off of joints and make you more stable. Exercise also helps to decrease the risk of falls, improve bone health, and decrease stress, depression, fatigue, and tiredness. All right, so rheumatoid arthritis, early diagnosis is important. So, early and progressive treatment is related to better outcomes and regular monitoring with the medicines and all that it's better to with their prognosis. Okay, so if you adopt these objectives, they leads to real remission, which is the real control of this disease with no pain, stiffness, swelling, or joint damage. All right, so excellent. Gout. Colchicine can be used to control pain when NSAIDs cannot be used. The mechanism of action is that it reduces inflammation in the joint caused by the urate crystals in the joint lining. Reducing that pain and discomfort, it also can be used long-term for chronic sufferers to reduce the tendency of a flare-up. Corticosteroids are effective for terminating gout episodes only when one or two of joints are affected. Once sepsis of the joint is excluded, the steroid can be injected directly into the joint. Patients also can get prednisone orally for 3 to 5 days. All right, so juvenile idiopathic arthritis. When treating these individuals, these juveniles with a chronic disease of arthritis, it is important to include their input, but also make sure that they are educated on how and why. Evidence suggests that these young patients with chronic diseases, such as juvenile arthritis, consider their self-image and how it affects their day-to-day lives when making treatment decisions regarding their disease. Making these treatment decisions comes at a difficult time in their personal and disease development. It is vital that they make the right decision because these diseases can have profound consequences. For many young people with arthritis, keeping on top of the treatment is a struggle. But if not properly managed by the condition itself, If not properly managed, the condition itself can have very serious consequences. So helping young people to identify the challenges and opportunities of different treatment options are a key step in enabling them to make decisions about treatment. All right, so when do you, or who do you refer these people to? So osteoarthritis, refer those people to like physical therapists or pain management specialists, especially if they're unable to walk, okay? Rheumatoid arthritis, if patients have pain greater than 6 weeks, they should see a rheumatologist because we need to make sure that they don't have our, as indicated in the evidence-based practices, early identification and treatment will likely reduce this joint damage and deformity and cardiovascular diseases. All right, so gout, referral may be needed to treat underlying diseases such as renal or cardiovascular diseases. Refer to nephrologists or heart doctor as well. Juvenile idiopathic arthritis, patients with chronic uveitis are at risk for vision loss. So these patients need to be referred to a qualified ophthalmologist to perform an exam every 6 months to make sure that they're not having any vision issues. All right, so when does a patient need to be followed up on? Educate your patients on when there is a need to call you or their healthcare provider. Place importance on the signs and symptoms of infection, such as fever, malaise, red swollen hot joint, as this can progress to a more serious condition. Patients that are on DMARDs need to make sure that their blood work is done and prescribed by the provider, and to follow up with the prescriber as needed to ensure efficacy of the treatment. Support an open line of communication so concerns can be addressed. And is there any questions? Thank you.